Cheers everyone. Good morning. Myself Dr. Sanjay Sharma, and today we are going to discuss about. First we'll talk about what is alcoholic liver disease, followed by etiology and pathogenesis, risk factors, clinical presentations, prognosis, and finally treatment. Chronic and excessive alcohol ingestion is one of the major causes of liver disease. The pathology of alcoholic liver disease comprises three major lesions, with the injury rarely existing in a pure form, namely fatty liver, alcoholic hepatitis, and cirrhosis. First, we'll talk about pathogenesis of alcoholic liver disease, importance of the innate background. Genetic factors. Studies on gene polymorphism suggest that genes encoding for enzymes that metabolize both ethanol and aldehyde influence the predisposition to alcohol dependence, sensitivity to alcohol, and ALD cirrhosis development. These genes include those encoding for alcohol dehydrogenase, aldehyde dehydrogenase, and C2 promoter allele of the gene coding for cytochrome CYP2E1. Variants of ADH genotypes encoding for less active alcohol metabolizing enzymes might facilitate liver damage by either delaying acetaldehyde formation, allowing higher intake, or diverting alcohol metabolism through non-ADH pathways such as CYP2E1 and other non-oxidative pathways which are potentially more toxic to the liver. ALDH gene polymorphism has been shown to influence alcohol sensitivity in some populations, namely Asians, and in women who develop ALD even consuming low amounts of alcohol. Polymorphism of CYP2E1 gene significantly differs among races and heavy drinkers with ALD. Alcohol consumption induces CYP2E1, and people with the C2 promoter allele exhibits a far greater ability to metabolize alcohol. This might increase free radical generation and lipid peroxidation, which promotes fatty changes in the liver. At present, the association between ALD and the polymorphism of genes encoding for ADH, ALDH, and CYP2E1 is far from being defined. Now we'll talk about gender. Women seems to develop ALD after the ingestion of less than half the amount of alcohol in men, which can be attributed to different reasons, including smaller volume distribution due to lower total body water content because of lower weight and a higher proportion of fat mass, lower gastric ADH activity, estrogen, which could contribute to ethanol induced liver injury by increasing gut permeability and portal endotoxin levels and amplifying the Kupffer cell sensitivity to endotoxin through increased expression of the endotoxin receptor CD14 and the pro-inflammatory cytokine tumor necrosis factor alpha. Ethnic differences. In the US, cirrhosis rates are higher in black men than in whites, while Hispanics present the highest cirrhosis mortality. Among active drinkers, Hispanics and blacks are more likely to have a twofold increase in serum aspartate aminotransferase and gamma-glutamyl transpeptidase when compared to whites. Now we'll talk about mechanism of liver damage. As you can see, alcohol follows three metabolism pathways. First one, alcohol is metabolized to acetaldehyde, followed by immunological damage, then necroinflammation and apoptosis. In the second pathway, it will undergo oxidative stress, followed by lipid peroxidation, then again join into immunological damage, necroinflammation and apoptosis. The third one, alcohol will increase intestinal permeability for the endotoxins, stimulate Kupffer cells, which will again activate stellate cells, fibrosis. Kupffer cells can also damage hepatocytes, followed by necroinflammation and apoptosis. We'll discuss this thing in detail. First, we'll talk about energy metabolism. Rate of ATP synthesis in liver cells exposed to ethanol is typically reduced. Chronic alcohol consumption depresses the activity of all mitochondrial complexes except complex 2 as several abnormalities in mitochondrial respiratory chain. This includes decreased activity and heme content of cytochrome oxidase, impaired electron transport and proton translocation through complex decreased cytochrome B content in complex 3, and reduced function in ATP synthase complex. As a result, the energy metabolism of liver cells can be severely impaired, and this would lead to tissue damage. Energy metabolism can also be altered by hypoxia. Chronic ethanol administration definitely enhances the oxygen uptake rate by liver cells because of the need of its own metabolization, which mainly occurs in the centrilobular area of the liver lobule. Hemodynamic changes are mediated by an imbalance between nitric oxide and endothelin 1 interaction, as ethanol-induced vasoconstriction is inhibited by endothelin 1 antiserum and enhanced by nitric oxide synthase inhibitor L-NMMA, that is Ng-monomethyl L-arginine. At high ethanol blood levels, hypoxia might ensue from the combination of reduced perfusion and increased oxygen demand. When blood ethanol levels subsequently decline, lobular perfusion is restored, and this can lead to reperfusion injury. Now we'll talk about the second cascade, that is oxidative stress. Oxidation of ethanol to water and carbon dioxide is mediated by three major hepatic enzyme systems, namely ADH, which is in cytoplasm, microsomal ethanol oxidizing system in smooth endoplasmic reticulum of mitochondria, predominantly CYP2E1, and catalase in peroxisomal membrane. All these biochemical pathways produce acetaldehyde as their toxic byproducts. Alcohol leads to increased liver oxidative stress via generation of highly reactive oxygen species and adducts. ADH generates acetaldehyde, which is subsequently oxidized to acetate by ALDH. Acetaldehyde can form hybrid adducts with reactive residues, example malondialdehyde adduct, acting on proteins or small molecules, example cysteine, mediating lipid peroxidation and nucleic acid oxidation. Mitochondria represent a main site where huge amount of ROS, that is your reactive oxygen species, are generated, leading in turn to cell damage and necrosis. The NADH induced inhibition of mitochondrial beta oxidation leads to accumulation of intracellular lipids, thus promoting steatosis. Excessive alcohol consumption is also associated with the enzymatic induction of CYP2E1 pathway of alcohol metabolism. The recruitment of this pathway may indirectly contribute to ALD development by excess production of superoxide radicals via the interaction of CYP2E1 with cytochrome reductase, which leads to electron leaks in the respiratory chain and ROS production. Again, ROS is your reactive oxygen species. The species produced in this cascade can interact with iron, that we call as Fenton reaction, generating even more potent hydroxyl ferryl and perferyl radicals, which perpetuate liver damage. And next cascade is your immunologic mechanism. Alcohol intake increases the intestinal permeability to a variety of substances that include bacterial endotoxins such as lipopolysaccharides. Lipopolysaccharides sensitizes your Kupffer cells by binding with the CD4 receptors. This bond activates nuclear factor kappa B, which in turn causes exaggerated transcription of pro-inflammatory cytokines such as TNF alpha and interleukin 6 and transforming growth factor beta. TNF alpha and IL-6 are mainly involved in cholestasis and synthesis of acute phase proteins. Cholestasis is just a decrease in bile flow due to impaired secretion by hepatocytes or to obstruction of bile flow through intra or extrahepatic bile ducts. TGF-beta may be critically involved in fibrogenesis through the activation of hepatic stellate cells. Last scenario, which should be characterized by necroinflammation, apoptosis and fibrosis, which leads to the progression of liver disease, finally culminating in cirrhosis. As you can see, the same cascade which I showed you before starting liver damage mechanism, same three cascades we just now discussed in detail. Now we'll talk about the favoring conditions for the alcoholic liver disease. First one is nutritional factors. Malnutrition is common in alcoholics because chronic abusers tend to substitute their daily nutrition calories with the empty calories provided by ethanol. Other factors include abnormal digestion, increased skeletal and vessel protein catabolism, and abnormalities in lipid metabolism. Malnutrition also increases the oxidative stress by reducing the assumption and promoting the depletion of endogenous antioxidants, namely glutathione and vitamin A, E and C. Patients with ALD are often deficient in folate, thiamine and pyridoxine, which enhance the likelihood of developing anemia, altered cognitive states and night blindness. Second one is hepatotoxic comorbid conditions. Chronic alcoholics exhibit a significant increase in hepatic iron concentration. ALD patients have an elevated hepatic iron uptakes in hepatocytes and Kupffer cells. However, it is not known why hepatic iron accumulation occurs and how it contributes to disease progression, which can be explained with genetic. Up to 70% of hepatitis C virus infected patients have a history of alcohol abuse. 30% of patients with ALD are infected by hepatitis C virus. Alcohol intake appears to accelerate the progression of chronic hepatitis C to cirrhosis. Activation of pro-inflammatory cytokines coupled with the direct dual hepatotoxic effect of both hepatitis C virus and alcohol may accelerate the cyclic bouts of necrosis and fibrosis leading to cirrhosis. Potential pathophysiologic mechanism for fatty liver includes following: decreased mitochondrial fatty acid beta oxidation, increased endogenous fatty acid synthesis or enhanced delivery of fatty acid to the liver, deficient incorporation or export of triglycerides as very low density lipoproteins, which we call as bad cholesterols also. Fatty liver is present in more than 90% of binge and chronic drinkers. The prognosis of severe alcoholic liver disease is dismal. The mortality of patients with alcoholic hepatitis concurrent with cirrhosis is nearly 60% at 4 years. Fatty liver is the initial and most common histologic response to hepatotoxic stimuli, including excessive alcohol ingestion. Accumulation of fat within the perivenular hepatocytes coincides with the location of alcohol dehydrogenase, the major enzyme responsible for alcohol metabolism. Continuing alcohol ingestion results in fat accumulation throughout the entire hepatic lobule. Appearance of steatohepatitis and certain pathologic features such as giant mitochondria, perivenular fibrosis and macrovesicular fat may be associated with progressive liver injury. Hallmark for alcoholic hepatitis is hepatocyte injury characterized by ballooning degeneration, spotty necrosis, polymorphonuclear infiltrate and fibrosis in the perivenular and perisinusoidal space of Dissay. Malar bodies are damaged intermediate filaments within the hepatocytes. Malar bodies are often present in florid cases but are neither specific nor necessary to establishing the diagnosis. Alcoholic hepatitis is thought to be a precursor to the development of cirrhosis. Fatty liver is potentially reversible with cessation of drinking. Cirrhosis is present in up to 50% of patients with biopsy proven alcoholic hepatitis, and its regression is uncertain even with abstention. As we are done with pathophysiology, now we'll talk about the risk factors, which can be quantity based, gender, hepatitis C, genetics, and malnutrition. In men, 40 to 80 gram per day of ethanol produces fatty liver. 160 gram per day for 10 to 20 years causes hepatitis or cirrhosis. Only 15% of alcoholics develop alcoholic liver disease. Women exhibit increased susceptibility to alcoholic liver disease at amounts more than 20 gram per day. 2 drinks per day probably safe. Hepatitis C virus infection concurrent with alcoholic liver disease is associated with younger age for severity, more advanced histology, decreased survival. Gene polymorphisms may include alcohol dehydrogenase, cytochrome P4,502E1, and those associated with alcoholism. Alcohol injury does not require malnutrition, but obesity and fatty liver from the effect of carbohydrates on the transcriptional control of lipid synthesis and transport may be factors. Patients should receive vigorous attention to nutritional support. Coming to the clinical features, right upper quadrant discomfort, tender hepatomegaly, nausea, jaundice, fever, spider knee, you can see the diagram, it is spider knee, jaundice, and abdominal pain stimulating and acute abdominal represents the extreme end of the spectrums. Portal hypertension, ascites, or varicose bleeding can occur in the absence of cirrhosis. That means liver damage is progressing towards the complication. Laboratory features. In fatty liver abnormalities are non-specific and include modest elevation of the AST, ALT, GGTP, hypertriglyceridemia, hypercholesterolemia, hyperbilirubinemia, which may be occasionally elevated. In alcoholic hepatitis, AST and ALT are usually elevated 2 to 7 folds. They are rarely more than 400 international units, and the AST to ALT ratio is more than 1. Hyperbilirubinemia is common. Modest increases in the ALT levels will be seen. Derangement in the hepatocyte synthetic function indicates more serious disease. Hypoalbuminemia and coagulopathy are common in advanced liver injury. Laboratory diagnosis of alcoholic fatty liver and alcoholic hepatitis. AST levels increase 2 to 7 folds but less than 400, greater than ALT. ALT levels will be increased 2 to 7 folds but less than 400. AST to ALT level are usually more than 1. GGTP, not specific to alcohol, easily inducible, elevated in all forms of fatty liver. Bilirubin may be markedly increased in alcoholic hepatitis despite modest elevation in alkaline phosphatase. Polymorphic nucleocells, if more than 5,500 per liter, predicts severe alcoholic hepatitis when discriminant function is more than 32. Prognosis. Critically ill patients with alcoholic hepatitis have short-term mortality rates more than 50%. Severe alcoholic hepatitis is heralded by coagulopathy. Prothrombin time is more than 5 seconds. Anemia will be present. Serum albumin concentration less than 25 gram per liter. Serum bilirubin levels more than 137 micromole per liters. And renal failure ascites may also be. So, to tell the prognosis of the disease, we try to find out discriminant function calculated as 4.6 into prothrombin time minus controlled prothrombin time plus serum bilirubin levels, which is in mg per deciliter, which can identify patients with a poor prognosis if your discriminant function is more than 32. Presence of ascites, variceal hemorrhage, deep encephalopathy, or hepatorenal syndrome predicts a dismal prognosis. Treatment. Complete abstinence from alcohol is the cornerstone in the treatment of alcoholic liver disease. Improved survival and the potential for reversal of histologic injury regardless of the initial clinical presentation are associated with total avoidance of alcohol ingestion. Referral of patient to experienced alcohol counselors, and alcohol treatment program should be routine in the management of patients with alcoholic liver disease. Nutritional and psychosocial states should also be evaluated, and supportive treatment can be given. Treatment for alcoholic hepatitis. As you can see, in alcoholic hepatitis, alcohol abstinence nutrition support should be given. If your discriminant function is more than 32 with the absence of comorbidity, you can give prednisolone 32 mg per oral daily for 4 weeks and then taper the dose. Alternatively, you can give pentoxifylline 400 mg per oral TID for 4 weeks, which has shown improved survival in case of severe alcoholic hepatitis. Thank you for your time. If you like the video, subscribe to my channel Dr. Sanjay Sharma, like and comment on the videos.